Hi, everybody. My name is Natalie Yeadon, and I'm the co-owner and managing director with Impetus Digital. For those of you who do not know what Impetus Digital does, is we've built some of the best in class asynchronous and synchronous virtual collaboration tools. We help pharmaceutical companies, medical device, biotech, life science companies have these engagements with payers, physicians, allied healthcare providers, and patients in things like advisory boards, working group, co-author working groups, etc. And unfortunately, since COVID-19, we've been helping companies with their brand plan rollouts, Salesforce training, etc. But what's really important here is that at Impetus, we believe that everything starts with a conversation. And we want to be the bridge or the platform to allow those conversations to take place. So with a courageous thought and with bleeding edge and really avant-garde provocateurs like the Mark Shapiros of the world, is we're hoping that we can all positively steer and direct this disruptive change in the healthcare system that we all know and love. And so that's what we're doing today. And I'm so pleased and honored to have Dr. Mark Shapiro with us today. So fantastic. He's actually a hospitalist, and he's also an associate medical director for the St. Joseph Health Medical Group in Sonoma County. So we all love that. So close to Napa, so great wine country. So we're gonna have to ask him about that. He is also has a medical degree from the Baylor College of Medicine, and he completed his residency in the internal medicine at the University of San Diego. So all wonderful California life. He is also the founder, host, and the producer of the Explore the Space podcast. And that's actually how I discovered Mark. And he examines a variety of different topics, including the interface of healthcare and society. And he interviews a whole series of thought leaders from across the spectrum in healthcare. He does focus on 4 key pillars, and we're going to kind of dissect those a little bit today when we're speaking. And those are around things like leadership and culture, illness and recovery, innovation and education, and the mental health and physical edge. So welcome, Mark. So happy to have you here today.
Thank you so much for that really kind introduction. I appreciate it. I'm delighted to be here.
That's awesome. So we started off just talking a little bit about this is, tell us a little bit about your background. So you were saying that you're still practicing. Tell us what the world has been like for you since COVID-19.
Yeah, so everything is different, just like for everybody else. Practicing physicians are no different than any other member of society. Everything is different. What's different is unique to each person, each role, each profession, each personal and interpersonal dynamic. I've been a hospitalist for about 15 years. I finished my residency in 2006, and I've been a hospitalist ever since. And what a hospitalist is and what hospital medicine is, it means I specialize in the care of the inpatient adult. So I don't have an outpatient practice. I only work in the hospital, and I take care of adults with basically any concern or complaint that would need them to be admitted to the hospital. Everything was kind of going along the same as it was for everyone else, just like it was for everyone else before COVID-19 hit. And I think for many of us, November of last year, we started seeing these news reports coming out of, Wuhan, China, and other parts of the globe, kind of thinking, this looks different, this feels different. I practiced during the H1N1 influenza pandemic, and just everything kind of looked, felt, and smelled different about this. And then when it really unmasked itself in the United States, we, just like everybody else, really had to pivot and be agile quickly. And obviously, everything is different. I don't speak in platitudes. I don't find them to be a very effective mode of communication. When I say everything is different, everything is different.
Right. So let's actually talk about some of those differences that you've noticed. So let's just talk about the day in the life of Mark Shapiro prior to COVID-19. You're kind of, so what did that look like? And
I barely remember.
And then the day after or whatever, literally the new normal is, what does the day in the life look like? So tell us, and let's linger on what does it mean by this big pivotal change?
Yeah, it's so, I laugh because when you said, what was it like before this? I'm having a hard time remembering. I haven't thought about it. I think the rhythms of life prior to all of this, prior to 2020, were, centered around the central focus being a solid clinician, being a solid practitioner, being a good colleague, being an attentive physician, staying up to date on new trends and being a good leader, continuing to develop my skills and all of that. I really enjoy clinical medicine. I've been doing it for a long time and I really love it. And so those were the same rhythms that they'd been kind of ever since residency, just constantly trying to improve, trying to find ways to do things differently, trying to identify weaknesses and build them out, and trying to really hone my strengths. On the side of explore the space, the same thing, really just trying to create this ecosystem, this communication network, and really enjoy that and focus on, as you mentioned, the 4 pillars of the show, really driving towards specific things. And on the show side, towards the end of last year, really focusing in a lot on really 3 kind of topics within those 4 pillars: climate change, gun violence and gun violence prevention, and gender equity. With the COVID-19 pandemic, really everything pivoted. On the professional side, on the clinician side, we all had to learn very, very quickly, and we all made ready to, in anticipation of a surge of sick patients. How do we use PPE? How do we properly don and doff PPE? Where will we have the patients in the hospital? I have a leadership portfolio with my medical group, so I was involved in how do we reorganize the hospital? How do we change our workflows? How does the medical group pivot from inpatient, from face-to-face visits, from 8 to 5 every day, to everything being done electronically, virtually, in the span of days and weeks? And that was an incredible experience. And I think it's an experience shared by many, many thousands of people around the world. And from there, it's just kind of building on those blocks, just what worked, what didn't. Okay, is it working? Can we sustain it? Did it not work? Why? How do we adjust it? And it's just been a continuous exercise in that. And on the podcast side, it's been kind of integrating those same themes around how are we getting better? How are we learning what's working? And just what is the experience like? I don't do didactic medicine on the show. Explore the Space is not what is the newest and best treatment for heart failure or stroke or COVID-19. It's what is the human experience around this like? How are we communicating around this? What's effective? What's hard? Where are the friction points? And how do we move through those? And then in parallel with that, certainly in the United States and around the world, the import of the Black Lives Matter movement and identifying systemic racism and how to be anti-racist and folding that into the work being done on Explore the Space. All of those things felt very meaningful and very, very important.
And I love that. And I want to spend a good portion of our discussion today talking about your podcast, but I want to linger a few more minutes on your life as a clinician, because there's a lot of people in our ecosystem that are pharmaceutical based, et cetera. Mm-hmm. And I'd love to kind of learn a couple of different things on this topic. First of all, when we as humans are pressed and we're put into stressful situations, sometimes there's components and aspects of ourselves. It's almost like an amygdala overload, where there's those components of us that emerge that sometimes aren't the things that we want to show people. Sometimes it's a good thing and sometimes it's a bad thing. You can sometimes see on the good side is how have the groups of people that you work with come together to flourish and to collaborate and to make something really bad potentially just, good. And then on the other hand, you can have people kind of blow up, infighting, cliquing, all sorts of other things that might be emerging that you may not have seen in some of those individuals. So can you share with us as a clinician working in the hospital environment, what did that look like? How were people showing the best or the worst in themselves? And how did you find yourself navigating through that?
I'll just compliment you first. That's a really great and astute and really important question, because it really draws out building blocks. We're going to be doing this work for a while. And it's a fabulous question. Speaking locally, speaking in kind of this region, Northern California, Sonoma County, we had an advantage. And the advantage was the fact that in the last 3 years prior to COVID-19, our region had experienced 2 catastrophic wildfires. And the hospital that I work at and the medical group that I'm a part of were instrumental in continuing high quality healthcare during those catastrophes. So it was the Tubbs fire in 2017 and the Kincaid fire in 2019. Going through that, Santa Rosa Memorial Hospital where I work, we stayed open during both of those fires. Working through that and experiencing that and feeling the pressure of a disaster, it took us down exactly that road that you just identified. And it, I think, helped a lot of people solidify where do they feel strong and identify where do they need to be better, because they want to stay part of that movement. They want to be part of the responses to these sorts of things. So when we had to reopen our incident command center and kind of ramp up all this stuff, we had done that work before. Obviously, the situation is different. The context is the same. So we were leveraging a lot of those same skills that we had done before. So I think for a lot of us in this region, especially, advantage might not be the right word, but we felt like we had a little bit of muscle memory around it. And so that's really helpful. The other thing about doing this in the context of medicine, of the practice of medicine, we have a very clear central dogma with all the decisions that we make. And this was drummed into me in my first job, and it's something that's really important to me as a leader to help those that are a part of my organization, for us to all have buy-in. Every decision we make, the patient is first, the team is second, the individual is third. If we make decisions based on that central dogma, we're going to be okay. It's going to be hard, but we're going to be okay. In this profession, we put the patient at the center. So we are thinking to ourselves, what is the right thing to do for the people that we're responsible for? Have we addressed that properly? Yes. Okay. Now we have a question. What's the best thing to do for our team or for our organization? Have we addressed that properly? Okay. I'm feeling really freaked out. I'm feeling scared and tired. Can we address my needs now? Making that third. That repetition, that central dogma is critical. And I think across the profession of medicine in large part, you see that in various manifestations, that's what people are doing. And I think that that has really given us a foothold in how we respond to a global pandemic.
I love that answer, and thank you so much for it. It's a beautiful dogma, and I think that was so eloquently put. So I want to just dissect that. And again, I do want to get to the podcast,
Sure,
but this is very timely. And I said, again, because there's a lot of pharma people that will be listening to this, I think that they're very interested in that. So when we're talking about the top of the line, which is, we call it patient centricity, as we look at the patient being the central hub of the focus, there has obviously been huge changes in the fact that especially with COVID and right in the middle, and we're still kind of steering through this, is not being able to see people in person. And so, I would really love to navigate about what that journey was like in terms of communication and trust building, and the rapid influx for the need of all things digital, especially people who might have really avoided it at all costs. So COVID being an accelerant of change that many people either were avoiding or just didn't want to have happen. So how did patient centricity roll through all of this, during COVID?
It was everything, right? So you identified a number of the key variables that we had to kind of muddle our way through. A good analogy, medicine is like an aircraft carrier on the ocean. It's not very agile. It doesn't have a history of being very agile when required to make population-based pivots, with one big exception, and that's COVID. Our entire profession has shifted 180 degrees in how we deliver care, primarily on the outpatient side. On the inpatient side, we're still face-to-face. We have barriers between us, whether it's PPE, face shields, things like that, but we're still kind of in proximity. On the outpatient side, that has totally been flipped over as areas have gotten better control. And my region is one where we have, thankfully, to this point, not surged like other parts of the United States. We are now able to safely do one-on-one visits in the office with the right precautions and with patient consent, and giving them an option for a digital platform. The degree and the speed to which we've done that in the United States is something I would have never bet a dime of my money on prior to this. And there's a number of variables in that, I think, but I think the fact that we've delivered is quite remarkable. Now it's a question of sustainability. How do we build it out? The digital piece is essential. We had the tools already in the toolbox. We didn't have to develop them, right? We're doing this over Zoom, so we're able to do that. We had adjustments made to allow patient privacy to still be in the foreground, but allow us to still use these platforms that weren't specifically created with HIPAA in mind. These sorts of things were obviously really, really important. You identified one critical piece: people who weren't necessarily facile with digital technology, who didn't want to do a telemedicine visit, who are used to doing an inpatient or face-to-face, and that's been critical. And there's been as much teaching as possible, as much encouragement as possible, and then also still making allowances and creating space to do those person-to-person visits. I think that as time goes by, more and more people will get comfortable with it. But there's another critical piece here, and it's really important that we call this out. This pivot has exposed and shined a very harsh light on a systemic inequity that's baked into how we deliver healthcare. It is an assumption, and it is a not good assumption to think everybody has this kind of access, because they don't. Our most vulnerable populations are ones who also don't have access like this, to have good quality Wi-Fi, to have a screen where they can take it and use it, to all of those different things, right? Those same social determinants of health, those same inequities that we're seeing put into very specific relief, impact the ability for us to deliver care to those people, because it's not that they don't want to come to the office. Sorry, it's not that they don't want to do a digital visit. They don't have the resources to do it, and we don't have a mechanism to provide them with those resources. That is the critical barrier, because in those same populations, whether you base it on zip code or household income or race or ethnicity or whatever you want to use, those are the ones that are most at risk. Those are the ones that are by far being disproportionately affected by COVID in terms of infection, admission to the hospital, and mortality. That is the bar that it's mission critical that we move that bar.
So really important, because I know this is one of the things, and now moving into your podcast, covering a variety of really important and very timely topics is really around sort of the Black Lives Matter, around the digital divide that you're actually speaking about.
Yeah.
All kinds of things are going on politically that are, you can look at the silver lining and saying this is a pivotal time for optimal change and progress, or you can be on the other side, is that we're on the brink of a civil war. Whatever side you want to look at. I mean, you can look at it from every angle. But what are you seeing in some of the guests you're speaking with and the topics that you're uncovering? What is the sentiment on this digital divide? And how do you see physicians advocating for or against this issue, and some of the things that you're trying to encourage in the discussions that you're having?
What I'm observing and what I'm feeling, and I would say participating in, is an awakening. And you use the word engagement, you use the word advocacy. Physicians for years, in my opinion, abdicated a responsibility to be advocates, not just for the patient that they're responsible for, but for issues related to the public health. There's a number of reasons for that. We've actually talked about that on Explore the Space, and it's something that feels very important to me because I experienced that and I was part of that. I didn't speak for a long time outside of the bedside, and certain issues at the bedside I didn't know how to speak about. I didn't know how to ask patients, do you have firearms in the house? Do you know how to store them safely? Do you have a gun lock? Do you keep the guns separate where your kids can't get to them? I never learned that language, and I never developed the comfort level to have those sorts of conversations. I can talk about anything else. I can talk about the most intense, scary, frightening, sensitive subject matter. Guns and gun safety, never learned it. Was not part of the curriculum, and we never talked about it. And so I think that sense of physicians understanding that they need to have that role and they need to be an advocate and they need to take those positions when the public health is at risk is where a lot of enthusiasm and energy has come from. And in parallel, physicians and healthcare professionals, I think, are realizing how much muscle they have when they do speak about it. There's a wonderful pediatrician in Flint, Michigan named Monahana Atisha, and she is the physician who exposed the lead contamination in the Flint municipal water supply. And she came on my show and she used a phrase, and I quote her on this all the time: physicians carry a megaphone and they have a responsibility to use it. And that really resonated with me. And I love quoting Dr. Hana Atisha around that, because that's what I think people are realizing. Doesn't matter what we've done up to now, it's what we do from now going forward. There's a whole host of things you can choose from. On the podcast, for me, it feels meaningful and right to elevate and accent lots of those different things, because my listenership is very diverse. It's people in healthcare, it's people outside of healthcare. I like people to be able to come in and say, that sounds good to me. This one looks interesting. Ooh, I've never listened to something about that topic. Let me try it. It's not a sequential show where you have to start at episode 1 and go all the way forward. You can pick and choose, and all of the content is evergreen, meaning it's good from 2017, it's good now. You can go listen to Mona Hanna Atisha's episode. It's a couple years old. She'll knock your socks off because she's amazing and she will always be amazing. That's where I think a lot of physicians and healthcare professionals are finding their footing. It's really, really exciting because I do feel like we can move the needle. I'm a pragmatist, but I do feel like that energy, that level of spokespersonship, that can move the needle on a number of critical topics.
And that really brings me to this topic of the advent of the podcast, which really in a lot of ways is this vehicle of a voice. And so you said it so succinctly and so eloquently that you were a hospitalist, you did what hospitalists were told to do. You kind of, follow the orders and then just, you kind of did what you did. And then suddenly found this new vehicle. So this opportunity to amplify your voice and for people to hear some of the issues. So, this is a whole conversation around physician voice in a way that we've never heard before.
Yeah.
And I think this is especially relevant for pharmaceutical companies as we think about, the kind of tried and tested, people will speak in an advisory board in these, private cloisters and all those other things. But suddenly we're hearing physicians speak about topics in a much grander scale. Tell us a little bit about, did you just wake up one day and said, I want to start a podcast? What was the advent of this journey? And then the second question is how do you feel that you have to skid along, corporate, and we call it like corporate speak about what you can and can't say and what's the white elephant, and is your organization, going to say, is this going to be a cancel culture issue for you? So I'd love to kind of expand a little bit on the start and the journey.
Sure, that's fun. So the start, I've always loved audiobooks. I've always loved kind of the art of storytelling since I was a little kid. And so that's always been part of kind of how I would like to entertain myself. An audiobook and things like that were always really important to me. So I was a very early adopter when podcasts kind of started. I was like, oh, cool. Topics that I like, there's these new podcasts, I can download them for free. They don't seem to have a lot of ads. This is really pleasant. I don't have to skip around on the radio trying to find something to listen to when I'm stuck in traffic. So in that respect, I was an early adopter. And then I was doing some work with a company that I continue to do work with called the Clinician Experience Project. And I encouraged the founder, who's a good friend of mine, Steve Beast, and said, this would really fit nicely to have a podcast. And I saw their team kind of paddle out and give it a try. And just thought to myself, I feel like I could do this. I was a sports writer when I was in college, so I kind of have a background in doing this. And look, I love talking. I won't pretend otherwise. I enjoy it. And the biggest barrier for me was just kind of getting over the tech piece. Found that it wasn't that hard. And May 2015, Explore the Space went live. I'm almost at 200 episodes now, and it's just been an extraordinary adventure. And the conceit, the concept that you described at the beginning is correct. It's issues. It's looking at the subject of healthcare very broadly from the perspective of those who provide it and the perspective of those who seek it. So people say, who's your audience? It's pretty much everybody, because we all really come in contact with healthcare in some form. That's a universal experience. The challenge has been, how do I want to shape the show? I'm a one-person show. It's just me. I bring in the guests, I send out the emails, I do the invites, I do all of it. And so in that space, I get to kind of shape it based on insight that I get from people who are really smart and a lot of kind of instinct. And from there, it's just been an evolution of who's saying yes to the show and then what themes do I want to get into. I'm struck by the fact, and I like to say this when I'm asked about it, I rarely have people say no when I invite them on the show. And this is not because of me. This is not because of Explore the Space. This is because people want to share the great things that they are doing. They want to talk about them, and they want to know that they're doing it for a broad audience. It's one thing to speak, as you said, kind of in that cloistered siloed thing. We use the same speak. I can use jargon and you would not know what I'm talking about, and vice versa. It's not because we're bad people. It's not because we're poor communicators. Our professions kind of encourage that. It's shorthand. But when we get to open it up to that broad audience, that's a thrill. It's an absolute thrill. And I really think that people who are at the apex of what they do, part of the reason they're at that apex is because they want to get their message beyond that silo. They want to talk to someone who has no idea, who just has that sense of intellectual curiosity. In terms of topic, subject matter, word choice, all of that, look, we maintain bounds of professionalism. The show, we try to keep it at that very, very high level. But if we're going to talk about sensitive topics, and the phrase that I like, we're going to step into that tension. We are going to talk about systemic racism in medicine. We are going to talk about gender equity and gender inequity in medicine and beyond. We're going to talk about climate change. We're going to talk about the fact that, you know, climate change is something that is caused by human activity, and we're going to talk about the impacts it's having on global health. We're going to do those things, and that is okay. We're not all going to agree on every topic. That is okay. But we're going to work through that stuff, and we're going to bring in people with that proven pedigree, with that real level of expertise and that real enthusiasm to communicate, to start to create that narrative, to start to create that place where, look, it is okay for us to discuss these things. We're going to find some common ground. We're going to find some friction points. That is all good. If we're not talking about it, that's the mistake, and that's what we want to avoid.
So what's really exciting about what you said is that you were somebody who, you know, liked podcasts and all that sort of stuff, but wasn't necessarily a digital guru or somebody who was totally tech savvy.
No.
But what's really cool about it is that you figured it out. Marie Forleo wrote a book called Everything is Figure-Outable.
Ooh,
And the reason I actually, Marie Forleo,
good
she's
name.
a,
Good
yeah.
book
So
title on there. That's
Everything
awesome.
is Figure-Outable is her
I
book.
like it. Yeah.
She's actually a YouTube virtual influencer, by the way, who created an entire platform. And what's really intriguing about this is really this, you know, kind of niching physicians as being non-tech savvy, or kind of the whole illusion around capturing, you know, incorporating electronic health records versus not, or the whole advent now in the acceleration of software as a medical device, and one day physicians having the wherewithal to start prescribing these from a digital pharmacy, or incorporating wearables as a way that they're collecting data from patients and leveraging, you know, patient portals and communicating with them electronically, or using telemedicine. There's a series, and this is just touching the iceberg of the start of these digital collaborations and communication portals, and they're learnable and figure-outable. What advice would you give to other physicians listening who are reticent, or who are waiting for things to go back to the way they were?
Yeah.
What would you say to them?
Before I answer your question, I want to pick up on something that you said, because I think it was a really astute comment, and it actually really resonated. You mentioned, and I don't remember the exact words that you used, but something around the idea of physicians are sort of labeled as being maybe not tech savvy.
Right.
And I want to take a step back around that concept, because I think you're right, and I think it's really smart. I think physicians and the profession of healthcare allowed the narrative of understanding of who we are, what we do, what we're about, to be shaped by others. I don't think physicians have done a good job, in the time at least that I've been in practice. I finished my residency in 2006, of shaping our own narrative, of expressing ourselves, of demonstrating our skill sets outside of the didactics and the clinical practice of medicine. And I think that this is an opportunity for us to kind of reclaim that space, not to beat our chests and show how great we are, but to demonstrate we are whole people. We are well-rounded individuals. We have diverse interests. We are part of the human experience, and we have something to say. And so you making that point, that actually really resonates. And I think that that's a lot of also what is driving some of this engagement and enthusiasm. Physicians are whole people too. When I'm talking with a patient about a sensitive issue that applies to them, I may not share it with them. I may have gone through the exact same thing. My family member may have gone through the exact same thing. There is that connective tissue there. There is that shared space there. And I think it's a really exciting time for people who look at physicians and look at healthcare as being kind of the, you know, the castle on the hill, and the physician as the patriarchal, all-knowing individual in the white. This is nonsense. We are people who are trained with and have a skill and have a desire to be of service, but we are still people. We are whole people with a broad variety of interests, of strengths, and of weaknesses. So that said, how do we help physicians move into that space? How do we help them step into that tension? You know, I think it's just allowing them to acknowledge first that it's okay to do it. That it's okay to say, I'm a doctor. I love being a doctor. I am also a brilliant artist. I am also a wonderful singer. I also love to tell stories. I'm a great writer. And when I write, I don't write about medicine. I write for fun. I write poetry. I think it's just all of these things are of a piece. It doesn't have to be digital tech. It doesn't have to be becoming astute at, using Zoom or creating your own podcast or being an expert on social media. This is all of a piece. It's what fills you with passion, what fills you with joy, what sustains you, just like anybody else. Go and do it. If it happens to be something in this digital space, the first thing I would say, look, ask for help. Don't reinvent the wheel. What you're trying to do, somebody else has probably tried to do before, and we like to share. In medicine, we don't keep any of our information, behind a firewall. If you have a question for me about management of heart failure, I'm going to share what I know about the management of heart failure. If you have a question for me about how to start a podcast, I want to share with you what I know about it. And I think that tradition of teaching, of learning, and of mentorship is really, really critical, that we leverage it into this other sphere of whether it's any sort of digital tech, using Zoom, using telemedicine, all of these sorts of things. It's the first thing we learn to do in our profession is ask for help. And then the kind of the statement that we use and the mindset that we have is see one, do one, teach one. And it's the same here.
That's beautiful and really, really well said. And so it's so funny because a lot of times, again, a lot of listenership being in the life sciences, pharmaceutical space, we typically think of education around therapeutic areas and those kinds of concepts. And one of the things that we try to do in our platform is get people to think beyond the pill, starting to talk about other learning activities and accredited education activities on some of the very topics that you're talking about, which is how to be human, how to be the better physician, how to be the empathic, provider. Eric Topol, as you know, in your neck of the woods, has written lots and lots of books about neural networks and about AI and all kinds of great stuff that's coming up. And we don't have to be the machines. I think truly the humanistic part of medicine is being the empathetic provider and the friend and the person who's going to listen. And that's what truly means to be human. And so with all of that said, I guess, my next question on that is, there is a fear factor around being replaced by the robots, by the artificial general intelligence that, is the imminent dystopian concern about all things human. So I guess the question to you is, do you see there being brand new skill sets that might need to be entrenched early on at the time of even, the faculty of medicine and the schools and the skills that are taught, and the way that education is continually instilled as a clinician, as a practicing clinician, in concert with, sponsoring companies like pharmaceutical companies? Does that need to change in what's being discussed?
Yes. Just to, yes. Well, just to take a step back, you mentioned Eric Topol. I've actually had him on Explore the Space twice.
He's awesome.
He was one of my earliest guests. We talked about The Patient Will See You Now, and then he came on again after he wrote Deep Medicine. And Deep Medicine, when I read it, that book made me mad. And part of it, I was kind of mad at him. I was like, this book is nonsense. I think I kind of missed the point. When he came on the show, I was ready to tangle. I was fired up. I was like, you're talking about the wrong stuff. But as he and I talked about it, I realized the view that I had, he and I actually had a lot of shared ground, because I felt like the book was more of a warning than of this sort of utopian future. And he's like, Mark, you're exactly right. This book is absolutely a warning. So I really appreciate that level of insight. And Eric is wonderful. And I can't wait for him to write another book so I can have him back on the show. But to your point, I mean, yes. All of the things that you just identified are opportunities and risks as technology advances. Specifically to the point that I think does give some heartburn and can become a talking point and become, it can trend on social media from time to time. Is the physician going to be replaced by the machine? I don't know. I'm very comfortable as a physician saying, I don't know the answer to your question, and I don't like to guess. I know that words that I carry, like Dr. Hannah Atisha tells us, they carry weight. So I don't like to guess, and I try to avoid speculating, because people can hang on the words of the physician, even if it's something sort of out of context of the practice of medicine. I think that the more important thing right now is for us to be doing what I think we're doing, which is identifying opportunities. How can this make our work better, smoother, more efficient for patients, for the organizations and communities that it serves, and then finally for the individual physician? And then how do we make it sustainable while still making sure that we're doing the best possible medicine? The third part of this, though, and this is one that I have come to learn, I would say probably more over the last 18 months. Right now, for me, digital tech and the ways that it's being implemented still feel inaccessible to the majority of, I'm in the United States, the majority of Americans. In the Western world, the majority of people in the Western world. It's expensive. It's expensive tech. It's complex. It requires a specific amount of time and attention that not everybody have. There are a lot of barriers to use. The place where I feel like we have to be very, very careful is before we just take it on board that using these things as normal, that we are very careful to identify our at-risk populations and make sure that they are integrated into that. They're already being left behind by the way we've been doing it. If we now really put our foot on the gas and accelerate, it'll be a bridge too far. It's a critical time for us to say, we can do this, we can do it at scale, we can bring everybody else on board that needs to be brought on board. That's the right thing to do. It's in all respect, whether you're looking at it from the perspective of delivery of care, of outcomes, of population health, of the health of your business and your margins and your share. It's all of a piece. These things can all work in concert. And if we try to put them in opposition, we're going to have a problem. If we take this opportunity to say, we have these tools, look what it can do in these populations. Okay, how do we get these populations into the fold? It's going to be that much stronger.
Oh, lovely. That's really well put. I know that there would be a lot of people listening to this right now who, again, a lot of pharmaceutical companies have medications and drugs and protocols, and there was a certain way that they were using them. There were certain cohorts and audiences and patient groups that were getting them. And of course, just like the digital divide, there's probably a large percentage of patients that were not getting access, for multiple reasons. But then COVID hits.
Yeah.
And now the haves become the have-nots, because how do you get them? How do you access them? And so there becomes a big concern for people that, outside of, contracting the virus, right? That's obviously a whole other management protocol, but just disease management in general. And then we're talking about, chronic versus immediate illness. So chronic diseases like cancer, some of these things that were happening, and suddenly the world stops, surgeries stop, and these progressive, diseases that literally could kill people, we're sitting there on the sidelines watching and probably grinning. And so one of the things I think that is going to be coming to the minds of a lot of the pharmaceutical companies listening to this is, what sorts of interventions do you think physicians were considering, or still today are going to consider, to manage these people with these chronic advanced diseases in this time where, there's probably bottlenecks and there's waiting lines and there's surgery issues because the things got backlogged? How are new therapies versus holding on to what you're doing? I think a lot of people want to understand the thinking of, is there switching happening? Are people just saying, hang on, this is not a time to change therapies, or, you'll have to just wait and see about your surgery. We would have done it before, but now because there's a backlog, maybe it's not as serious. What does this look like now? I mean, in terms of prescribing of drugs or not, and surgeries and everything else, what's your thoughts there?
This is the question of the age. I mean, this is an era defining question. And you've mentioned the pharmaceutical industry a few times, so I'll speak directly to that industry from my perspective. This is just like the delivery of healthcare has had to pivot dramatically to using platforms like telehealth and things like that. I think it's a real opportunity for the pharmaceutical industry, kind of en toto as a whole, to look at how they ensure that the right medications get to the right people at the right time. The number of people that have moved at a population level from that place that you described, right, the haves, towards the have-nots because of the COVID pandemic, we don't know the numbers yet, but it's really ugly. We know it's ugly. We may not have specifics yet because it's all still too new. They still need the right medication to the right people at the right time. To not do that is an abdication of responsibility to the public good. That's just the reality. If you have the opportunity to be of service, you have to serve. And I think that would be my call to, that would be the call to action and the opportunity to redefine how the pharmaceutical industry interacts with the population that depends on them. And and that's not an overstatement. They depend on that industry to provide the diabetes medications, the antihypertensive medications, the asthma control medications, right? People cannot do without these medications. And then also the way more advanced therapies, right? The immunologic therapies for autoimmune disease and the cutting edge therapies for cancer treatment. They're all in the boat. And if we had an opportunity to say, we are going to commit to be sure that people who are hypertensive, acknowledging that hypertension in the United States and coronary artery, like these are the things that drive morbidity and mortality, that they get the medications that they need on time and at a cost that is manageable to the individual so that they can stay on the medications without skipping a beat. You are going to redefine how the history books look at this entire industry. That's the opportunity that's there.
Yeah, fantastic. Very important. I think the other thing as well too is there's just so many topics associated with your key pillar, which you were talking about, is the core focus was around patients and patient centricity. Now I know we talked a lot about gun violence. Obviously every country, and every geography has their own legislation around guns. We're not as apt to have that in Canada and less in Europe than it is in the US, but obviously it's a reality in the US and that affects healthcare. You also talked about systemic racism and other inequalities that has just been very prevalent. What is the whole premise been around this, including the most recent opioid crisis, with all of that kind of crashing into this crescendo, almost like the perfect storm? Is how has this changed and tweaked your mindset as a hospitalist, your colleagues, your institution? Is this changing protocol? Is it changing cultural memes? What are you hoping to achieve in this sort of perfect storm that we're emerging through?
Superb question. I would just add to that perfect storm. We've got the wind, we've got the rain, we've got the smoke, we've got the fog. Climate change is the one that I would add to that. I actually refer to climate change on social media and on the show as that's our apex predator. That's the one that no one can escape. It is undeniable. It manifests in different ways. I'm sitting here, it's 10:45 p.m. a.m. Pacific as you and I are recording. I'm really hoping we don't have a blackout because California is experiencing rolling blackouts because of our extreme heat event right now.
Right.
And we just had the most bizarre lightning storms in the past 48 hours. So just as we talk about this perfect storm, it's critical that climate change and the impacts of climate change are part of that. I would say, right now we're in phase 0 of how to address it. It's just coming to grips with all of these things. It's so easy to just say, no, I can't. It's too much, too many, too scary. We're coming to grips with, we can't do that. There's a lightning storm outside, whether I want it or not. It's really hot outside, whether I want it or not. All of these sorts of things, right? It doesn't matter whether you want them or not. You have to face them. And I think that that's part of being a good citizen, being a good leader, being a good doctor, being a good co-owner and managing director of a company. It's just, it's part of that human experience. And I think that that's still where my impression, kind of phase 0, early phase 1, it's we're just in that first step of a long journey of just identifying the things as you just did. And then how do I bring these on board for my own kind of, my community, my family, my profession? Where do I work locally? What does my leadership portfolio look like? Am I, one physician in a solo practice, or am I president of the United States and everything in between? It's just coming to grips with that, but we do need to do it quickly. There's a certain amount of time that's okay to just kind of learn and reflect and take on board, and then it's time to start acting. Then it's time to lean into the wind and walk.
Absolutely. So many cultural things going on. And I think one of the big pieces that's going to emerge out of this is probably the complexity and the immensity of the mental burnout and other mental health issues. So you talked earlier about the core focus being your patients, followed by your team. And that probably is an issue that's going to be experienced by all and the above. So what is your sense, or some of the discussions that you're having around what this complex issue is? What's the immensity of this problem? how are digital applications going to play a part in a pivotal role in the management of these emerging mental health issues and PTSD and everything else that might be coming through? Who knows if there's going to be an increase in an analysis, a retrospective analysis of an increase in addictions and all kinds of other interesting behaviors. So what's your thoughts on that?
We're at risk for all of it, and I agree with you that, you know, we're just sort of seeing kind of anecdotally, but all of these things are on the rise, whether it's, you know, gun violence or domestic violence, or, you know, people being at risk for substance use disorder, and then any part of the spectrum of mental health, whether it's depression or anxiety or whatever the case may be. And all of it has obviously just been lit on fire because of COVID, because of the disconnection from our normal lives that it's caused. I think that the first thing that the digital space is able to do is to help us feel like we're still connected. I can still text my friends. I can still FaceTime with my friends. I can't hang out with my friends, but I can feel connected. And I, like everyone else, have had stretches where I have felt very isolated. Even with my family around me, it still can feel very isolating, and it's okay to say that out loud. And part of, I think, the real strength of just that digital world that we all are fairly comfortable with is just being able to use it and still acknowledge that there's others who can't. They don't all have an iPhone. They don't all have internet access. So those same social determinants are still there. But I think you're absolutely right that in this whole space, we're all vulnerable people too. And this is incredibly hard. It's incredibly stressful, and it feels unrelenting. This high tempo, this vice-like crucible, it's not stopping. And it's very, very tiring. I think learning best practices and then sharing them digitally is critically important. I think using the technology to amplify and support one another is critically important. And I think being judicious with how we criticize, being judicious with how we are rude, mean, all those things, that we need to be better at calling it out and reconciling it and putting it away, so that when we are able to amplify and elevate and support, that kind of has primacy. I know that sounds kind of pie in the sky, and as I'm hearing myself say it, I mean, I'm not naive. I know that it's a huge challenge, but when we're able to pass a compliment to one another, that's elevating. When we bash each other, that's going to grind somebody down, and it's actually going to grind both of you down. If I was to start insulting you right now, first of all, you'd close the interview and you'd be angry with me, but it's going to hurt me too, right? Because why would I do something like that? As opposed to you and I having a nice conversation and exchanging compliments when we're done and feeling good about the experience, that helps us move forward into the crucible that's still there.
It's very interesting, and it's a very divisive situation right now. But just like one needs to look at it, just like when rock goes through the vise, it creates a diamond. Is there something very, very pivotal that will emerge from this? We just can't see what you can't see. It's like the Johari window of you don't know what you don't know, and we're just kind of emerging into a into a new dimension. Mm-hmm. And so
I think it's important to say then, what we can do is, as we're moving towards that space, we can give each other guidance on best practices to walk the road. I've done it this way. It was not effective. I might suggest you use a different way. Or, hey, I see you feel like you're doing well. Are there things that you're doing that I could replicate? That's, again, that digital platform, that digital space, that interchange of ideas, that democratization of information, which is a theme that comes up on the podcast a fair amount too. It's critically important. If there's things that you are doing well in Toronto, I want them here in Santa Rosa, fast, and vice versa, right? So if we can do that, we really should take the opportunity. If there's things that you're observing there, like these things are detrimental to all of the things that you have identified as being at risk, and I applaud you for having that level of vision, we should distribute that information as quickly as possible. And obviously the digital platforms allow us to do that at scale.
Beautiful, beautifully said. Now, you actually raised something very important, which is we need to stay connected. Community, humanness, the human condition. This is what makes us human. It keeps us alive. I hear, because again, I'm a digital geek, really big on AI. What makes humans? What is consciousness? You know, and the Turing test and people like with the Ray Kurzweils and the Peter Diamondises is that we can build neural networks and they can become human. So it's a whole discussion. At the end of the day, there's something very unique excuse me, about being human. But what's interesting here is about the use of technology in taking the place of humanness. There's a company called Replica. I don't know if you've ever seen a movie called Her, where somebody fell in love with a computer software algorithm.
Yeah.
And we're seeing more and more of this. In fact, statistics are showing that people, especially people with mental health disorders, feel less inhibited and more apt to be open with an algorithm, like a Wobot or some other computer, than they are to a quote unquote biased human. So is this something that we need to be looking at as a society? I know we kind of delved into this a little bit about being a hospitalist versus not. The question comes down to is, does the skill sets of a physician in the future look different? Do they become much more of a computer scientist or a data scientist and navigator of data and analytics than they are? What do you foresee in the future of being a physician?
We could spend some serious time on that. I love it. I will counter your study with one that I learned about. So Maureen Bisignano, who runs the Wellbeing Trust, came on the podcast. She is extraordinary. She is an amazing person. She was a nurse, and now she's become this amazing executive doing all this interesting work. One of the things that's been a focus of study for the Wellbeing Trust is something that they term and have written about, the epidemic of loneliness. Their intervention, and the one that she shared on the show, and the study is available open source, was identifying rising rates of depression and isolation amongst the senior population in a town in England. The intervention was to use the post office, to use the postal workers who are at everyone's house 5 days a week at least, delivering the mail, to have extra time to say, how are you? Knock on the door. How are things going? Make eye contact, shake hands. How's it? Look at the house. Does the house look okay? Does the person look okay? Develop that rapport. The outcomes from that intervention were extraordinary. So what I would say, the thing that will always set physicians, nurses, healthcare workers apart, no one can do what I do when I walk in the patient's room, notice the book on the table and say, I've read that book. What do you think? And we can shoot the breeze about their book for 5 minutes. And then we can talk about their heart failure and their whatever. When I do those things, I'll never forget. I walk in the room, the Wimbledon final is on. It's Rafa versus Fed. It's like must-watch TV on a Sunday morning. And I hung out and we talked tennis for like 15 minutes. I'll never forget that interaction. And then, it was actually, I apologize. It was the Friday of the semifinal and we talked tennis. On Sunday, I came in and I said, are you watching the tennis? And he said, yes. And I said, can you turn it off for a minute? Because I'm taping it and I want to watch it. And he said, Dr. Shapiro, no problem. Hang on. He turns it off. I come in the room. We chat. I said, don't tell me the score. And we talked a little about the tennis. The next day I see him, we talked, it was the 2008 epic Rafael Nadal, Roger Federer final. The next day we talked about it. We're still managing the acute illness that's brought him in the hospital. But I don't remember actually what he had. I have no idea. But I remember talking tennis. You can't replace that. Nothing will replace that. Nothing will replace those sorts of interactions. I would suggest, and I think that that's the opportunity for physicians to continue to get really good at acknowledging we hold those skills, we carry those skills, we can be really good at those skills, and we can deliver.
For the pharmaceutical companies that are listening, a lot of them are really struggling with what does the new interactivity between pharmaceutical company in the typical way that they've done it with the prescribing physicians, allied healthcare providers, et cetera, et cetera. Those would be sales representatives, medical science liaisons, medical advisors, people who interact with hospitalists, physicians, prescribers. What sort of advice would you give to those companies about how they can provide that level of humanness and connection and, being able to make sure they're helping doing and, with the best things that could be possible for patients moving forward? What advice would you give them?
There's an opportunity for service recovery. I think there's a real opportunity for service recovery and for us to reconnect around a sense of shared purpose. I'll be very transparent. I don't interact with pharmaceutical representatives in my practice. I won't accept pens. I don't go to their dinners. I won't interact. I don't go to their kiosks when I'm at conferences. For right now, for me, I don't feel like we have a sense of shared purpose and I don't want to be involved. That's where I am, and that's just me. I am also amenable to doing it differently, and I would love to be able to do it differently. I will also say I'm not alone in my approach as a physician to how we can do this work and how we're doing it now and how we could do it better. I think there's a real opportunity for service recovery. I think there's a real opportunity for improved collaboration. The stakes have never been higher. We're ready. I think we need to make sure that we understand why we are doing things, really build on that sense of shared purpose. I would really appreciate being reached out to. Mark, what is meaningful to you as a physician, and how can I, as a pharmaceutical representative who lives in Sonoma County, better support you in that mission with the tools that I have as part of a pharmaceutical company? It's a multi-billion dollar industry. Every tool that we could possibly need, we could execute on together. I think there's an opportunity to build on some shared purpose there, but I would say it would start with some service recovery and just trying to connect around where is our shared purpose and how can we act on it together.
I really appreciate the honesty and the authenticity of that. And I'm sure a lot of other people around the table would be as well. And I think it's very well put. We're in a new times where everything is different. This is the new normal. And what a typical, what they call return on investment metrics, they're all changed. They're all in a big, big pile, and we're being tossed like a salad. And now we have something new to emerge.
Yep. It's a great analogy.
So this is exactly the point around really what Impetus Digital wants to do, is we want to be the bridge or the collaboration platform for these courageous conversations, getting beyond the pill discussions, beyond the brand, and talking about healthcare, talking about positively disrupting and changing and modifying the way we all interact, creating that shared vision and building that together. That's right. So for anybody who's interested, we would love to speak to you to see how we might be able to work together, might be able to create that platform, working with the Mark Shapiros of the world, other colleagues, other people in the Brain Trust to create something new. So we will be leaving the contact information for Mark Shapiro and his podcast. Highly recommend that you go out and listen to some of this great stuff. It'll probably really tweak some food for thought, some interesting ideas for your own organization, and some of these courageous things that you might want to do. Connect with Impetus if you're looking to create a virtual touch point to start having some of these conversations and doing some of this feedback work with your own prescribers. We'd love to hear from you. Thank you so much, Mark, for a wonderful conversation. I could probably speak to you for hours and hours. So absolutely loved it. Thank you all for listening today, and wishing you all a great day ahead.
Thank you.